for the invitation to come and talk with you today. So the title of my presentation is 21st Century HBPC. And by the end of this presentation, I'm hoping that you will feel the excitement of home-based primary care and its role in geriatrics and in our healthcare system. Home-based primary care provides care in the home for vulnerable individuals who are failing traditional methods of primary care delivery. And HBPC has seen a growth in this country over the past 20 years. HBPC supports the triple aim conceived by the Institute for Healthcare Improvement as imperative for improving the U.S. healthcare system. And those three aims are improving the patient experience of care, including quality and satisfaction, improving the health of populations, and reducing the per capita cost of healthcare. HBPC supports these goals for home-limited adults by providing patient-centered care and consistently scores high in patient satisfaction. HBPC demonstrates quality care in a number of domains and also decreases healthcare costs, emergency department visits, and hospitalizations for home-limited adults. So why HBPC? HBPC provides preventative care, support, and timely interventions that preempt avoidable emergency department visits and hospitalizations. Also gives vulnerable and underserved patients access to continuous care, alleviates social stressors that can contribute to poor health, improves patient satisfaction, and achieves better outcomes at lower costs. These are the objectives for today's discussion. I'm going to describe the societal, demographic, and economic forces supporting the growth of HBPC in the United States, identify key features of HBPC programs and which patient populations are best served by HBPC, list key successes of the VA HBPC program and the Centers for Medicare Independence at Home demonstration project, and then evaluate and we'll discuss the advantages and pitfalls of technology and innovation in delivering quality HBPC to frail, home-limited individuals. In October of 2018, the American Academy of Home Care Medicine and the John A. Hartford Foundation published a white paper entitled Home-Based Primary Care, New Standard of Care Cures High Costs of Care for 2 Million Sick and Frail Homebound Adults. The first title in this paper was The Invisible Homebound, an Unrecognized Driver of Spiraling Health Costs. Home-based primary care patients are 2 million homebound adults throughout the U.S. who are unable to visit or have difficulty visiting a physician's office, have severe functional impairment, disabilities, and/or multiple serious chronic conditions, may require palliative or end-of-life care, and they are often not cared for by disease-specific management programs. 81% of individuals 65 and older have multiple chronic conditions, and chronic illness is expensive. The vast majority of Medicare expenditures are accounted for by patients with multiple chronic conditions. The top 5% of healthcare spenders, or 18.2 million people, accounted for an estimated 60% of all healthcare costs, and that's a total expenditure of $1.6 trillion. 56% of healthcare expenditures are spent on people with functional limitations. HBPC is a proven, cost-effective program that provides proactive, preemptive care, targets healthcare's major cost drivers for the invisible homebound by decreasing readmissions, emergency department visits, avoidable complications, and medication errors. So 100 years ago or so, home house calls were relatively common. Approximately 40% of all patient encounters in 1930 were house calls. But over the subsequent 50 to 70 years, that decreased a lot, such that in 1980, there were only house calls were only accounted for about 0.6% of the face-to-face encounters with providers. In 1993, New England Journal of Medicine reviewed Medicare claims data and found a 30% drop in house calls between 1988 and 1993, from 1.6 million to 1.1 million, and down to only 984,000 house calls in 1996. This was to the point that in 1997, New England Journal of Medicine wrote an article entitled "House Calls to the Elderly, a Vanishing Practice Among Physicians." So what are some of the reasons for the decline in house calls? It was felt that possibly a change in technology as our technological developments improved in medicine, such as CT scans and MRIs. We really needed to have patients come to medical centers, hospitals and clinics in order to get a lot of those tests done. Fear of liability was another concern, and then poor reimbursement. However, over the past 20 years, the decline in medical house calls has reversed. In 1996, there were less than 1 million house calls. However, in 2016, there were 2.2 million house calls and 3.2 million visits made to domiciliary facilities like assisted living facilities and group homes. So what are some of the reasons for the house call resurgence? Technology has advanced such that we have more what's called point-of-care testing now, testing that we can do right where we see the patient. For example, if we're doing a home visit, we're going to talk more about that. And then the fear of liability seems to be unsubstantiated. A review of legal cases in the US from the 20th century found only 2 litigated lawsuits stemming from millions of house calls, with one of the 2 cases culminating in dismissal. Furthermore, financial barrier under Medicare standard fee-for-service structure has been significantly reduced. In 1996, house calls paid approximately $3 more than an office visit, with an average Medicare payment of $64. In 1998, Medicare added higher-level house call codes and increased payments, reflecting the increased complexity of care at home. And house call payments have continued to increase, and most pay 100% more than in 1997. Furthermore, there's other reimbursable services that providers who do house calls can bill for, such as preventative care, supervision of interdisciplinary teams, and care plans. Another positive is that Medicare grants HBPC practices leeway in determining the medical justification for a house call and does not bind them to the Medicare definition of being housebound. There are 10,000 new baby boomers who join Medicare every day, and that will occur until 2029. The 85 years of age and older group is the most rapidly growing age group in the US, and this age group is projected to quadruple between 2000 and 2050. Half of this population requires assistance with at least 1 ADL, and 1/4 of this population requires help with 2 ADLs. 1/6 of them require help with 3 or more activities of daily living. In 2011, there were 2 million homebound individuals, but this number will double over the next 20 years. Another reason there is increased demand for HBPC is that the US federal rebalancing legislation provides incentives for states to increase home and community-based services that enable people to remain at home and reduce nursing home placement. The percentage of government dollars going to home and community-based services increased from 1% in 1983 to 55% in 2015. Therefore, there's an increased demand for home-based primary care to assist with more functionally impaired individuals to stay in their homes. Recent healthcare reform incentivizes value over volume and penalizes hospitals for excessive readmissions. Thus, healthcare systems desire to institute programs that decrease readmission rates. Medical house calls have been shown to reduce hospital readmissions by 25 to 50%, and therefore reduce or eliminate readmission penalties. Medicare has developed programs that share in cost savings produced by better care coordination and quality of care. One private multi-state HBPC program called US Medical Management generated over $59 million in shared savings in its first 2 years of participation in the Medicare Shared Savings Program, ACO. This program cares for approximately 18,000 home-limited patients per year in 14 states. In 2016, $44.5 million was saved for Medicare, with an average savings of $2,500 per patient. And they managed an overall quality score of 97.25%. So not only did they save Medicare a lot of money, but they also maintained high quality of patient care. So in summary, factors contributing to the growth in HBPC include a rapidly aging population, especially in that group that we call the oldest old, which is 85 and above. That population tends to have more functional dependencies, high cost of healthcare. There is a movement in our healthcare system towards patient-centered care, and HBPC helps to support this type of patient-centered and value-based care. Our advances in technology help to support growth in HBPC, and HBPC, as we'll see later, has been shown to be an effective model of healthcare delivery that allows individuals to age in place. Okay, so this is a little visual break. This is our Oahu HBPC team of nurses. So hardworking nurses that go out in the field every day, seeing patients all over this island of Oahu. Okay, next we're going to talk about key features of HBPC programs and which patient populations are best served by home-based primary care. So some of the common features of home-based primary care programs include interdisciplinary team care. Healthcare team members need to have skills in primary care, geriatrics, and palliative care. The patient care approach is very patient-centered, and identifying patients' goals is critical in providing high-quality care. HBPC programs provide complex chronic disease assessment and management, geriatric syndrome assessment and management, family and caregiver support. They often access durable medical equipment to provide support to home-limited older individuals, access community resources, manage polypharmacy, provide symptom management and end-of-life care, and address mental health needs. So who provides HBPC services? Most HBPC providers work in partnership with interdisciplinary teams that can include primary care physicians, nurse practitioners, physician's assistants, nurses, social workers, emergency medical technicians, pharmacists. In the VA, we also have occupational and physical therapists, nutritionists, and recreational therapists. Most HBPC programs target the frail, home-limited elderly with multiple chronic conditions and functional impairments. However, there are some various types of HBPC programs, and some target younger, home-limited patients with neuromuscular disease, such as MS, ALS, traumatic brain injury, cerebral palsy, and cervical spine injuries with quadriplegia. Some target high utilizers of the acute care system who are not home-limited, yet have difficulty engaging in the traditional healthcare system. And then some target other specific populations, such as ventilator-dependent clients, or people with complicated diabetes, or people with sickle cell anemia. HBPC programs naturally provide for an interface with palliative and hospice care for patients due to the fact that HBPC programs have an annual mortality rate of 20 to 25%. Quality end-of-life care leads to most patients, more than 70%, dying at home, and the national average is 33.5% of patients dying at home. So HBPC can really serve a critical role in helping patients die at home, which is where most patients actually identify that they would rather pass away, is at home. HBPC programs need to determine how large a radius they can cover. Fee-for-service programs tend to limit geography due to reduce uncompensated travel time. Some programs increase efficiency by targeting assisted living facilities where multiple patients can be seen on the same day. Programs with at-risk, value-based contracts may travel greater distances to see patients but the shared cost savings that result from preventing avoidable hospitalizations more than cover the cost of the additional travel time. HBPC models mainly differ in terms of mission, such as target population and geography, and business plan. Examples of different missions include longitudinal primary care for vulnerable home-limited patients, improved end-of-life care, episodic home-based care to augment traditional primary care for at-risk patients, improved transitions of care with reduced readmissions, caring for a specific disease state, and teaching. Payment structures include fee-for-service and value-based contracts, and then we're going to go through some of the roles within the healthcare system. So home-based primary care programs are mostly located within academic centers. They address hospitalized, frail, and complex patients that are costly to the health system. Hospital systems can benefit from downstream revenue from home health and hospice referrals. So I had to look up what does downstream revenue mean. And it's interesting that downstream analysis strengthens value-based initiatives. And basically the idea is that you follow the patient across the healthcare system's continuum of care in order to identify the maximum value that a particular system has for providing healthcare for patients. So for example, a 2-physician HBPC practice in a Chicago area academic center accounts for 7% of home health and over 12% of hospice referrals, resulting in over $300,000 of downstream profit for that center. The practice also has lowered hospital mortality rate by implementing palliative care principles. If a health system participates in at-risk contracts with an insurer, the HBPC program can reduce costs on the most expensive patients. HBPC can assist hospitals in reducing readmission penalties, and it's also a fantastic teaching opportunity for teaching geriatrics, transitions of care, home health, interdisciplinary collaboration, and palliative and end-of-life care. Home visits have been shown to fulfill all 6 of the ACGME competencies and relate to at least 16 of the 22 family medicine milestone project sub-competencies. Freestanding HBPC programs are divided into fee-for-service and value-based. So fee-for-service programs tend to try to optimize their billing. They closely watch costs, and so as I mentioned before, they may try to see patients where they're more congregated and it's easier to see a larger number of patients. They may need to look for additional revenue sources such as ancillary services, philanthropy, and value-based contracts. Value-based contracts are Medicare and Medicaid managed care contracts on a per member per month basis. Some programs offer primary care. Others collaborate with the patient's primary care provider to provide case management, improve patient caregiver education, and provide technologies such as telehealth to augment care in the home. Hospital at home is another unique type of home-based primary care program that has 2 different types, substitutive and early discharge. So substitutive means that you're actually, instead of the patient who is appropriate for hospitalization, instead of them going into a traditional hospital, the hospitalization is substituted by a hospital at home stay. So the patient is treated for that acute medical condition at home instead of in the hospital. Early discharge means that a patient is assessed in the emergency room, then admitted if needed, and then is discharged early from the hospitalization in order to receive the rest of their acute care in the home setting. And this can decrease hospital stays. The target conditions, this program was originally developed by Dr. Bruce Leff from Johns Hopkins. And the target conditions that he identified were acute exacerbations of COPD, CHF, cellulitis, and community-acquired pneumonia. And this has largely stayed as a theme for hospital at home programs as they've developed throughout the country, although there's a lot of variability. Hospital at home involves more frequent visits and 24-hour access to an on-call physician and nurse. Benefits are in cost savings to healthcare institutions. And they tend to be adopted in countries with single-payer healthcare systems, such as Australia and the UK. They have been implemented throughout the VA system and Medicare managed care, and there is a movement towards providing a payment model for hospital at home in Medicare. So in summary, HBPC populations, HBPC targets frail individuals with multiple chronic conditions who are failing usual care. There are different models of HBPC, including those affiliated with academic centers, private practices, hospital at home, the VA. HBPC programs can help hospitals decrease readmission rates, help private practices earn value-based payments, and provide teaching opportunities for trainees. Okay, our next visual break. Oh, somehow my words didn't come out here, but this is one of my HBPC patients. He's an 89-year-old male who has diagnoses of Alzheimer's disease, COPD, congestive heart failure, hypertension, and hearing impairment, visual impairment. He's married, he lives with his wife, who is his primary caregiver. He was admitted to our home-based primary care program in, I think it was September of 2018, and prior to that he had a couple of emergency room visits and hospitalizations for various issues. Since he's been in our home care program, it's been almost a year, he hasn't had any hospitalizations or ER visits. Our interdisciplinary team has worked closely with the patient and his wife to help him with his maximizing his functional abilities in the home, and as well as working with, our social worker has been working with the wife to help her with her caregiver strain and burden. And our nurse has been helping with the complex medications that he's prescribed, including inhalers. And so fortunately, he's been able to stay out of the emergency room at hospital. This was a home visit that I did with he and his wife. I just want to how she keeps him healthy. She installed a railing in the living room, and she has him walk every day. To the tune of Tennessee Waltz. And he sings. He sings as he walks. So very effective health preventative measure. Okay, now we'll talk about some key successes of the VA Home-Based Primary Care Program and CMS Independence at Home Demonstration Project. So VA Home-Based Primary Care. This program targets individuals with complex chronic disabling disease with the goal of maximizing the independence of the patient and reducing preventable ER visits and hospitalizations. We use an interdisciplinary team, provide longitudinal comprehensive care in the home setting. So what are some differences between VA home-based primary care and Medicare skilled home care? VA HBPC targets chronic disease, whereas Medicare skilled home care targets remediable conditions. VA HBPC provides comprehensive primary care in the home, whereas Medicare skilled home care tends to be more problem-focused care. VA HBPC is interdisciplinary. Medicare skilled may have involved one or more disciplines. VA HBPC patients are homebound, but homebound is not strictly required. For Medicare skilled home care, they must be homebound. We do not generally provide skilled care in VA HBPC, whereas that's one of the requirements for Medicare skilled home care. VA HBPC accepts declining status. Medicare skilled home care emphasizes improvement. VA HBPC reduces hospital days and is limited by geography and intensity. So the characteristics of the VA HBPC population are a mean age of 77.7 years. 96% are men, but this is a shifting. 69% are dependent in 2 or more ADLs. 50% of the veterans are married. A third of the spousal caregivers have limitations in their ADLs. And our patients tend to have a lot of chronic medical conditions, including sometimes neurologic conditions. We have a lot of mental illness in our VA HBPC population. A recent VA study of 9,425 newly enrolled HBPC patients found that the program's annual Medicare costs were 11% lower than projected costs. Enrollment in VA HBPC improved access while achieving a combined VA plus Medicare 36% reduction in hospital days. And VA patient satisfaction rose to the highest level ever at 83%. This table here shows the use and costs of newly enrolled dual department of VA and Medicare home-based primary care beneficiaries 6 months before and during HBPC enrollment. So the first line, you can see that the Medicare hospital days decreased once they were enrolled in home-based primary care, and that was statistically significant. And then total Medicare cost per patient over 6 months decreased from $4,000 to $3,500, also statistically significant. And VA hospital days, was a 50% decrease in hospital days. And VA plus Medicare hospital days decreased by about 37%. This is another figure that shows the average annual cost of care prior to and during HBPC participation. And it shows a 24% reduction in cost during HBPC participation. HBPC also decreases the risk of acute ambulatory case-sensitive conditions. There was a study by Edwards et al. In 2014, which was a retrospective cohort study involving patients admitted to the VA and non-VA hospitals from 2006 to 2010. It demonstrated that enrollment in HBPC was associated with a 5.8% decreased probability of ACSC condition hospitalization in 1 year among elderly veterans with diabetes. Over the past 10 to 20 years, VA HBPC has made important gains in the identification of dementia, requiring a mental health provider to be on each team, improving technology. Approximately 15% receive some form of home telehealth, and then expanding to rural areas. A third of the patients in HBPC are in rural areas, and this mirrors the percentage of patients who live in rural areas, the percentage of veterans who actually live in rural areas. So speaking of rural areas, this is our Guam HBPC team. I was fortunate enough to be able to go there in March to spend a week with them. We have an incredible team there at the VA. There's a CBOC, which is our a clinic outline clinic, but the VA home care team is in a separate location. They're mostly out in the field, seeing veterans in very rural areas. If you haven't been to Guam, the patient population there tends to be, they tend to get chronic conditions at a younger age than our population here. And so we do have a lot of very complex and difficult patients in our home care program. This is one of the, on my way to see a patient in Guam, and it took me over an hour to get to this patient's house in Guam. So you can see how we've been able to expand our services to very rural areas. HBPC is patient-centered. Feedback from veterans and caregivers is consistently positive. Patients and families describe that the care is personalized and respectful. They appreciate the trust that occurs when we go into the home and we're in a patient's territory, we're not on our territory. And just by stepping into someone else's home, you immediately realize and recognize that, oh, this isn't my territory, this is the patient's territory, and therefore I need to offer that type of respect. We offer assistance with medication management, care coordination, benefits to caregivers, and care provided by care at home. So let's move on to the CMS Independence at Home demonstration. VA HBPC provided crucial verification of scalability, clinical outcomes, rural viability, and economic sustainability that led to the support and passage of the Medicare demonstration of HBPC, which is the Independence at Home demonstration. The IAH demonstration began in 2012 to test a delivery and payment model for HBPC teams. It was initially a 3-year demonstration, but it's been extended twice by Congress and CMS due to successful saving results, and will run through December 2020. IAH practices care for patients who meet the following criteria: 2 or more serious chronic conditions, and they need assistance with 2 or more activities of daily living. They had to have had a hospitalization and received post-acute skilled nursing or rehab services in the past 12 months. This demonstration provides quality performance metrics that can be used for value-based risk-sharing payment models. The program awards incentive payments to HBPC healthcare providers to reduce Medicare expenditures and meet designated quality measures. So these are the quality measures, and the programs need to meet 3 out of 6 of these in order to receive their incentive payments. So follow-up contact within 48 hours of a hospital admission, hospital discharge, or ER visit, medication reconciliation in the home within 48 hours of a hospital discharge or emergency visit, annual documentation of patient preferences, and then they have certain designated thresholds for all-cause hospital readmissions within 30 days, hospital admissions for ambulatory care-sensitive conditions, and emergency department visits. In year 4, IAH saved Medicare approximately $33 million, or about $384 per beneficiary per month. This follows savings from years 1 to 3 that, when combined with year 4, amount to about $63 million in savings and high-quality care for Medicare patients. In year 4, the greatest savings were from reduced inpatient hospital admissions, which are 40% of the per beneficiary per month savings, and skilled nursing facility services. Over a 4-year period, there were 1,800 fewer hospital admissions, greater than 3,400 fewer emergency room visits, greater than 400 fewer unplanned readmissions. The IAH demonstration is now in year 6, and it has proven to be one of the most successful new clinical and payment models supported by CMMI and CMS. So in the second year of IAH, CMS awarded incentive payments of $5.7 million to 7 participating practices. The first 2 years of the IAH program saved approximately 10 times more than pioneer accountable care organizations. In summary, VA HBPC is a well-established program since the 1970s that has adapted and grown to serve more veterans all over the U.S., including rural areas. The CMS Independence at Home demonstration was modeled after the VA HBPC program and has demonstrated remarkable success in terms of providing patient-centered quality care in the home that saves money and allows patients to age in place. Okay, this is one of our nurses, and she was doing a home visit in Kahalu not too long ago, and she shared these photos with me because she said she got to the residence and that she came across this road with all of the holes and bumps in it, and she was too scared to drive her car in there, so she parked out, on the highway, and she got her nurse's bag and she hiked into the patient's house. So these are examples of some of the things that our nurses do every day. Okay, our last topic is technology and innovation in HBPC. So this could be a whole talk or then some, and so what I tried to do is just kind of picked a few things that I thought were interesting or relevant. So we'll touch on point-of-care testing, assistive technologies, and telehealth. So what is point-of-care testing? Basically, it means that you are providing care at testing at the point of care. So it can be done in a clinic, in an emergency room. For example, they do point-of-care testing to check a PT and INR. If the patient has to go into the OR stat, you can get a result quickly. And it can also be done in the clinic, and then now we can do point-of-care testing in the home. Portable lab instruments can provide data such as basic metabolic profile, BNP, cardiac enzymes, blood gases, and these can be processed with 3 drops of whole blood in 2 minutes. Portable chest x-rays and ultrasounds are also available. Portable EKG readings, now we can do these on smartphones. And I don't mean to suggest to you that the VA is up on all of these things, but these are theoretical things that we can do. And definitely some private practices that do home care are using all of these advanced technologies. Smartphones can provide medical texts, drug databases, and EMRs. So we do actually have in the VA now the capability of using our iPads to get into the electronic medical record, and so we can look up patients' lab results, we can look up their last visit to their cardiologist, and then we can give them real-time feedback in terms of how their healthcare is doing. Okay, so this is an example of point-of-care testing. This is called an iStat machine, and iStat machines can provide a number of different tests, such as blood gases, chemistries, PT coax. That's probably the most common one, is the coax. The positives of point-of-care testing are that it's portable, you can get rapid results, and it helps to steer the provider in the right direction until a more complete workup can be done. The downsides of point-of-care testing is that there's no consensus on how to use these devices effectively, there's limited accuracy, and there's limited types of testing that can be done. Assistive technologies. So I decided to spend a fair amount of time on technologies for fall detection. Falls detection technologies is a growing field. They can be divided into 3 categories: wearable technologies, which are divided into automatic and non-automatic, ambient technologies, and combination of wearable and ambient technologies. A scoping review of 118 studies demonstrated that technologies are in the initial stages of development. Most studies are descriptive, consistent with the literature on health technologies at home. So this is an example of a wearable technology. This is a medical alert system with fall detection. So some companies now, for an additional fee per month, offer the ability to actually automatically sense when a patient falls to the ground. The normal medical alert systems that patients wear around their neck, the patient, once they fall, they actually have to press a button, but some of them now have automatic sensors that can detect a fall and call a 911. Many technologies are being developed, but the field is still young in terms of demonstrating efficacy of these technologies for use in the home by elders. 80% of older adults do not use their alarm buttons. For example, a pendant linked to a 24-hour call center after a fall due to difficulty in activating it or for fear of disturbing caregivers. And I can personally attest to this. We prescribe medical alert devices to a lot of our home, let's say, patients who live by themselves, and don't have anybody to help them if they fall. It's often challenging to have them, to actually get them to wear their device. So assistive technology is actually underutilized. This is a photograph of ambient technologies, and there's a lot of research being done in this area. And this is an infrared sensors that can be installed throughout a patient's home, and the claim is that they will help to detect falls in various parts of the home. The gaps in the literature prevent making recommendations for one technology over another. There's a lot of variability of the technological outcomes recorded in the studies. None of the studies evaluate outcomes related to health and quality of life in older adults and caregivers. Most studies do not evaluate the devices in real living conditions, such as at home or long-term care environments, and many studies use young healthy subjects. So even though there's a lot of work being done in this area, there's still a lot of work that needs to be done in terms of figuring out how applicable this is to our patient population. Assistive technology and dementia. There was a Cochrane review in 2017 that could not identify any completed studies that met the inclusion criteria. There is no high-quality evidence to determine whether assistive technology is an effective means of supporting people with dementia manage their memory problems. This is a very active area of research, and there are many quantitative studies identifying the types of activities that people with dementia want support for. There's many studies investigating device design and usage, but there are not many studies evaluating effectiveness. Okay, so I'm scared to do a video again, but is it okay, John, to try it? Okay. So this is an example of a assistive device for an individual with cognitive impairment. It's called Reminder Rosie.
Mom's always been a busy lady, staying active and social, but these days, she's forgetting things more often. She'd like to keep living at home, but I'm starting to worry about it. Between taking care of Mom, my work, and my family, things can get a little crazy. Just when I thought I might snap, I found a lifesaver, Reminder Rosie. Rosie reminds Mom of important calendar events, like appointments and medications. The best part is, reminders are recorded and played back in a loved one's voice. Just talk to her and she responds. Hello, Reminder Rosie.
Can I help you?
Record reminder.
Please record a reminder.
Hi, Mom. Your doctor's appointment is in 1 hour. Remember, turn off the stove before you leave. Love you.
Reminder saved.
Rosie prompts me to set the date and time for the reminder, and she's all set. On the day of her appointment, Mom hears my voice message and makes her doctor's appointment on time. It's that easy. Mom can even ask Rosie the day, time, or a complete list of daily events, and Rosie responds. Reminder Rosie gives Mom independence and me peace of mind. Never forget tasks again with Reminder Rosie.
So yes, we do use Reminder Rosie in the VA home-based permanent care. Our occupational therapist who sets this up for our patients says the downside of this is that when they go out, like if they go out to lunch or whatever, they don't have Reminder Rosie with them. So she helps them if they have a smartphone, set up reminders on their phone and things like that. Okay, and then this is another example of some sensors that can be installed in patients' homes for issues such as a patient who has dementia with wandering or high risk for falls. There's a lack of consistent terminology in the assistive technology literature. Assistive technology, one of the challenges in doing studies in this area is that if you think about it, assistive technology has to be personalized to the individual. So you have to go in there and you actually have to set it up. You have to explain to them how to do it. And so doing a randomized controlled trial on assistive technology is kind of a near impossible. Therefore, randomized control trials in the field should be needs-based rather than intervention-based. Support for memory problems is the unmet need most frequently mentioned by people with dementia and their caregivers. Small-scale studies of memory support devices appear promising, and there is now a need for more robust evaluation of effectiveness addressing complex methodological issues. In general, older adults don't experience privacy concerns. Sometimes that comes up, the ethical aspects of doing this sort of home monitoring. But most studies that have looked at this show that most of them are not as concerned about privacy because they acknowledge these technologies are meant to help them. Elders want to be involved in the research and evaluation of the service and technology, and this helps to give them a sense of control. Participants generally feel that technology enhances their ability to age in place. And then these are some apps that our occupational therapist uses for some of our patients. Mindfulness, we do have a lot of patients who have PTSD, and that's sometimes the reason that they're actually homebound is because they're too afraid to leave the house. So she works with them on mindfulness or keeping them active, such as with games like Sudoku, and audiobook apps can also help a lot of our patients. And then our OT also helps them to learn how to text, because this can be helpful for hearing impaired patients or other disabilities. Okay, so the last thing I'm going to talk about briefly is about telehealth. In the VA, we have something called Care Coordination Home Telehealth. And this is a national program that provides secure technology-assisted health information exchange for monitoring and care coordination for community-dwelling veterans with poorly controlled chronic conditions such as diabetes, hypertension, heart failure, chronic lung disease, and others. And daily monitoring of patients through home telehealth can enable care coordinators and primary providers to detect early warning signs and intervene preemptively, thereby preventing expensive ER visits and hospitalizations. So for the VA Home Telehealth Program, one review of over 40,000 veterans who are enrolled in this program showed a reduction in hospital admissions of almost 20% and admission length of stay of 25%. And then briefly I want to mention, this is a relatively new program in the VA called Video on Demand, where we can actually do face-to-face encounters with patients, with a provider at their office and the patient at home. So I recorded myself doing a video on demand encounter. This is a patient who is not enrolled in HBPC, but he is homebound, and he's actually a patient in the Queen's home health home care program, and Dr. Tom asked me to try to see this patient on a video encounter because the patient is so homebound that in order to come, one of the requirements to get into the VA is you have to have a face-to-face encounter. So in order for the patient's wife to get the patient in, it would have cost her $300 for gurney transport. So it was really just too burdensome for them. So I decided to do the initial VA encounter so that he can get our VA Home Environmental Health Aid program, where an aide comes in to see the patients for 10 hours a week for hands-on care.
So can you tell me a little bit about what you do during the day? What is your day like?
So you can see the patient's on the screen there. I had to blur out his face, but I'm listening with my earbuds to what he's saying over the internet. We have these video encounters now.
Oh, okay.
So for these, we can actually put these in as encounters, just like it was a face-to-face encounter. We don't build the VA, but we code it just the way that you would code a face-to-face encounter. So for home-based primary care, we have something that's called VERA, and so in order to get the maximal allocation, it's basically an amount of money that's allocated by Congress to different facilities for the complexity of care of patients. So in HBPC, in order for us to get the maximal VERA allocation, we have to have seen the patient 10 times within a fiscal year. And this will count for 50% of our VERA requirements. So this should be a growing field to do these types of video on-demand encounters. But we're at the very infant stages right now. In summary, there are exciting developments in technology that allow HBPC clinicians to have more information at their disposal at the point of care. More studies need to be completed to evaluate their effectiveness in improving care, efficiency, and cost. There is much research and development occurring in the field of assistive technologies for elders to age in place safely and successfully. Most studies need to be completed, more studies need to be completed to standardize the terminology and quality measures of these technologies. Telehealth is a promising area that could increase access and improve care for home-limited and rural patients. Before I end, I just want to mention that the AA, that's the American Association of Home Care Medicine, and the Home Centered Care Institute and other organizations are working together to ensure HBPC becomes an essential benefit for chronically ill, medically complex, and homebound patients. Their initiatives include identifying and validating HBPC quality metrics as a foundation for value-based payment models, expanding and training a qualified workforce, and increasing awareness among payers, policymakers, and the public of the value and availability of integrated HBPC programs and networks. So there's definitely a shortage of HBPC providers. HBPC is only taught in a minority of medical nurse practitioner and PA schools. Only 1,000 providers report making over 500 house calls annually in the US, and many rural areas are left out. The Home Centered Institute is addressing workforce development through the launch of a multimodal curriculum to train clinicians. So my conclusions are that HBPC provides high quality patient and caregiver-centered primary care in the home setting for home-limited individuals. HBPC programs that deliver individualized geriatric and interdisciplinary team-based care have demonstrated high patient satisfaction and cost savings across different types of practices and healthcare organizations. More work needs to be done to identify and validate HBPC quality metrics as a foundation for value-based payment models. Home technologies are generally well accepted by elders, but more studies need to be done using a frail population in the home setting to properly ascertain effectiveness. HBPC will continue to serve an important role in our healthcare system. The future development of strong HBPC programs that can support the frail aging population will require expanding and training a qualified workforce and increasing awareness among payers, policymakers, and the public about the value of HBPC. So that's the end of my talk. I appreciate very much your attention. Are there any questions? Oh, okay. Okay, so the question was how do we at the VA home-based primary care select our patients? So that's a good question. They're referred usually from primary care, sometimes from mental health. And we have criteria, and mostly it's patients who are failing usual care and that tend to have a higher, that have high hospitalizations and emergency rooms, visits, tend to have a lot of chronic medical conditions. There is some work in central office in terms of trying to look at risk measures. They've tried to, kind of group together, patients who have high rates of hospitalization, chronic conditions, and they have measures that they look at, and they try to encourage us to look at those particular groups of patients. So sometimes we reach out to primary care providers who tend to have patients with lots of hospital admissions, and we try to recruit those patients. Does that answer your question? Yes?
You mentioned some of the IPP members. Talk about the ones that you have.
Yes. Yeah. So we have primary care providers are nurse practitioners and physicians, RNs, social workers, occupational therapists. We have 2 that service the Pacific, the Hawaiian Islands, and then we have registered dietitians, 2 of them, pharmacists, and part-time recreational therapist and physical therapist. Which one?
A home health program,
Home health.
yeah, it's kind of an offshoot of that.
Okay, the question is about home health. We don't have our own home health program, so if a patient needs home health, like skilled home health, then we refer them to community home health agencies and the VA pays for that.
Lavonda, based on your own experience, you were the plan program yourself. What are the optimal ratios and what are the specific tasks for which each person is best suited? For instance, what would kind of the ratio of nurse practitioners and the caseload of nurse practitioners as compared to the co-dependent position? And who would you send out, for instance, if there was a change in condition, things like that?
Okay, good. So the question is kind of thinking about the case mix and the how many patients per provider, nurses, etc. And actually the VA has done studies about case mix for HBPC, and so there's actually a guideline that we follow for that. But generally speaking, because, for example, our VA population is so, tends to be so frail and complex, we do a lot of case management, and then a lot of our veterans also have dual care, so they're getting care the VA as well as in the community, and so it makes the care with an extra layer of complexity. But generally speaking, our RNs case manage between 20 to 25 patients. Physicians can manage up to 100 patients, and then nurse practitioners usually on the order of 50 to 70 patients. The OTs manage, well, we have two OTs for about 200 patients, so they manage about 100 each. The social workers manage about 70 to 100 each. So generally speaking, compared to a primary care caseload, it's a lot different. But in spite of those, you can imagine the cost of care for that type of workforce is very high. But if you think about the downstream types of cost savings in terms of keeping patients out of the emergency room hospital, it more than justifies those types of professional team members. So we try to, and our administration tends to ask us questions all the time because they don't understand what we do, and they tend to do a lot of bean counting. Primary care has 1,000 or 1,200 patient panel, and we have 100 patient panel, so they don't understand why that is. But our existence is justified by not by bean counting, but by cost savings to the healthcare system. And so a lot of the work we do is case management. In terms of sick visits, you asked about that. The nurses will be able to triage a lot of those, and they do a lot of the sick visits. We do sometimes have to, have our nurse practitioner go out on the sick visit, or the patient does sometimes have to come into the ER. Does that answer your question? And I'm happy to share with you those case mix document.
Yeah, can I make some observations from the advantage of primary care, private practice person who used to do house calls? With the advent of payment reform and Medicare and the insurance programs, that rendered home care, home visits uneconomical. Honolulu has changed. Yeah? Now you got all these issues we never had before. You got to do traffic, parking, all of that kind of stuff. Other issues, limitations with the whole visit kind of thing. You go over there and visit, you have no access to any kind of laboratories, no imaging. And even if you're going to prescribe medications, if they're homebound, how do they get the medications? So there are limitations to that. The other issue is that, we could have used a lot of ancillary help, home health aides, nurses, that kind of thing, but Congress has not bestowed upon us any of these potential monetary things that allow us to do this kind of thing. In fact, it seems to me that the whole focus of everything has been to minimize payments to the providers out there, which leaves us no opportunity to set up any of this kind of stuff. But what does happen is that you have individuals who are going to set up programs like this on a for-profit basis, which renders us completely out of this. I know the VA has these programs, and I guess it does work. But it works because you're cutting back on hospital stays, which decreases inpatient hospital considerably. It makes it more than economic. And it would be also for the private hospitals too. But there is no mechanism for sharing in that profit to compensate us for doing this kind of thing. So, you know, I really doubt that you're going to see private practice out there doing any kind of revival of this system.
Yeah. Thank you for that comment. Anyone want to comment on that?
Yeah, I actually think your talk on this is really a very timely talk. Because where I see things is, you know, 20 years from now, home visit programs are going to be just as large as the nursing home programs. And it's only a matter of time before Kaiser and HPH will move in this direction. There's a lot of economies in it. There's a lot of positive for primary care doctors who have a time managing patients like this. And there's a lot of positives for healthcare systems. I think it's just a matter of time. Your time, your talking.
Thank you.
Just a comment on that.
Yeah.
I agree that in the private practice setting,
Yeah.
unless you are hired by a hospital, I think it saves the hospitals money. But in the private practice setting, I agree it's unaffordable.
Yeah.
Which is why a faculty practice cannot do home care, because it's unaffordable without sharing the savings. Somebody has to share the savings with us, and the people who get the savings are the hospitals. But I also agree with Warren.
Yeah.
I think the hospitals would wise up to this.
Well, I agree, actually, the hospitals, you know, I work for Queens, you know, hospitals program, and, you know, the hospitals actually lose money because we're reducing hospitalizations, we're reducing ER visits. So it's HMSA, Medicare, it's the insurer, so there needs to be better negotiation between them. Maybe Kaiser's a stronger player in that, but better negotiation to go back to the insurance carriers and say, this money has to be come back to providers or systems. How big is the VA program right now? Like, how many patients do you carry right now total?
We have about 350 across the Pacific Islands. It includes Guam. Yeah. So, but yeah, it's a good point about private practice. I mean, the old model of being able to follow your patients in the clinic and at home, and because you have that relationship with them, and you want to serve them where they need. And I think it's too bad that you know our healthcare system has been squeezed so much. So it will be nice if there was an avenue for that. Thanks for sharing that.
I think your talk is predicting what's happening in the future. You know, you mentioned a lot of baby boomers coming of age retirement. You're going to survive a lot for 10, 20 years. But they also have a lot of children. And they don't have just 0 or 2 children or 1 child involved. They have lots of kids, baby boomers and children. So they're going to be looking for answers to the problem. And the other problem is many of the veterans have passed on. What about, do these benefits cross over to surviving spouses? Many of them have spent their lives serving the military.
Right.
So
the
the spouses,
Do the spouses of veterans benefit from? You know, they won't get a lot of the direct benefits, but you know, if a veteran is receiving income from the VA and that veteran passes away, then that spouse can still, you
but in
know, have
context
income.
with relatives and patients who have spouses surviving on the mainland, I'm not sure how many veterans are eligible for. So I was going to ask you the question, where are the VA centers in this program active on the mainland? Are they all like Tripler or are they different?
Your question is about VA home-based primary care programs on the mainland? Pretty much every major VA medical center has a VA home-based primary care program. It's disseminated throughout the whole country.
I'll talk to you later.
Okay. Thank you all so much for your attention. Appreciate it.